Each year, the KAFP invites 4 family medicine residency programs in the state to select residents to give their CME presentations on a topic of their choice. This is to help fulfill their scholarly activity requirement for their programs and to showcase the great benefit of being a member of the KAFP. When FAMMed Forward was canceled this year due to the COVID-19 crisis, we knew we wanted to find a way to proceed with having these presentations and to provide residents a venue for which to present their material. With that in mind, this series of 3 webinars of resident presentations was born. Today, we will hear 3 of the 10 resident presentations, followed by 20 minutes of open Q&A time. You are welcome to type your questions into the chat box during the presentation, and all questions will be answered by the speakers at that time at the end of the presentations. The webinar is CME eligible. Participation in this live series activity has been reviewed and acceptable for credit by the AAFP. Physicians should claim only the credit commensurate with their extent of participation in the activity. Participation today in this live webinar is eligible for 1 CME credit. Following the close of this webinar, participants will be emailed a survey to evaluate the speakers as well as indicate their CME earned for the KAFP. And the KAFP will report this CME for members. So without further ado, please welcome our first speaker for today, Hannah Smouse from the Ascension via Christi Family Medicine Residency Program in Wichita. Dr. Smouse will present on broad-spectrum antibiotics in children with acute respiratory infections. Dr. Smouse.
Good afternoon.
Oh, there you go.
Okay, sorry. Good afternoon, everyone. Thank you for having me. Like Dr. Beard said, I am going to be presenting on broad-spectrum antibiotics in children with acute respiratory tract infections. I am currently a first-year family medicine resident at the Christi Family Medicine Residency here in Wichita. Okay, so the 3 goals of today's presentation,
Let me see if we can.
Sorry.
Sorry, Michelle, you have to enable participant screen sharing. You can go ahead.
Okay. So the 3 main learning objectives for my presentation today are to compare and contrast broad-spectrum and narrow-spectrum antibiotics, to discuss treatment recommendations for children with acute respiratory tract infections, and then to describe the considerations for prescribing antibiotics for children with acute respiratory tract infections. Okay, so why this topic? Acute respiratory tract infections, which include acute otitis media, sinusitis, and group A streptococcal pharyngitis, account for the majority of bacterial infections in children. And antibiotics for these 3 account for 50% of the medications prescribed for children. Sorry. Okay. So another reason why, so the Choosing Wisely campaign looked at antibiotics prescribed in the pediatric population, and it showed that out of the 50 states, Kansas was the 12th greatest state for prescribing antibiotics, primary care physicians being the #1 specialty to prescribe antibiotics, and amoxicillin being the most prescribed antibiotic. One thing that we want to consider is that with overprescribing antibiotics, this can be associated with antibiotic resistance, drug-related adverse events, and also increased costs for the healthcare system. So this presentation was based off of an article that was published in JAMA in 2017 entitled The Association of Broad versus Narrow Spectrum Antibiotics with Treatment Failure, Adverse Events and Quality of Life in Children with Acute Respiratory Tract Infections. The purpose was to compare and contrast broad spectrum versus narrow spectrum antibiotics, and it went about this by using 2 studies, a retrospective cohort study that assessed the clinical outcomes by assessing treatment failure as well as adverse outcomes after a 14-day course of treatment, and then a prospective cohort study that looked at primary outcomes of treating, including quality of life, other patient-centered outcomes, and then patient-reported adverse events. The main findings were that there was no increased treatment failure in narrow spectrum group, and no difference in the clinical outcomes. However, the adverse events, there were some differences. So a few definitions as we go through this presentation, which I mentioned earlier. The three main infections that we're going to be grouped into the acute respiratory tract infection group would be acute bacterial sinusitis, acute otitis media, and group A streptococcal pharyngitis. And what does it mean by treatment failure when we talk about that? It's a child having the same acute respiratory tract infection diagnosis and a new prescription for a systemic antibiotic throughout 14 days of treatment. So if they failed one therapy and then had to get a new antibiotic, that is considered a treatment failure. And also what are included in the adverse events: diarrhea, candidiasis, a non-candidal rash, allergic reaction, and vomiting are the main ones. Okay, and then the three main antibiotics that were grouped in the broad spectrum category in this study are augmentins, cephalosporins, and macrolides, and the narrow spectrum including amoxicillin, penicillin. So this study showed that there was no difference in treatment failure rate, but there were increases in diarrhea and rash in the broad spectrum antibiotic group in comparison to the narrow spectrum antibiotic. There was no difference between missed school in children who were prescribed either of these or parental work days taken off. So one thing that we looked at in this study, social determinants of health, showed that Caucasian patients, interestingly, were far more likely to get broad spectrum antibiotics prescribed to them compared to African American and Hispanic populations. Why is this? A few of the things that we can think about were possibly cost effectiveness. So narrow spectrum antibiotics are much more affordable than broad spectrum antibiotics. And also, what kind of antibiotics are being prescribed in the academic setting where they're possibly more aware of these more recent articles versus the private practice setting. And then common adverse events, which we talked about a little bit, included diarrhea, rash, and candida, highest with augmentin and lower with amoxicillin and azithromycin. The JAMA study was not the first to report increased adverse effects with broad spectrum antibiotics either. There was a recent meta-analysis that showed similar findings in showing that the rates of these common adverse events were highest with augmentin. Another consideration that we should have when prescribing antibiotics to our pediatric population, and we see a warning that comes at saying this patient is allergic to penicillin, is this a real penicillin allergy? A lot of pediatric patients are prescribed a broad spectrum antibiotic because they're given a flag with a penicillin allergy that's not actually a true allergy. So over 90% of patients labeled with a penicillin allergy are actually not penicillin allergic. So it's important to consider in these patients skin testing to confirm the penicillin allergy before prescribing them possibly a broad spectrum antibiotic that could lead to resistant bacterial infections, increased risk of C. diff, etc. So it's important to make sure that penicillin allergic patients are truly allergic to penicillin. Okay, so the next few slides are just going to give the recommendations and the indications for treating acute otitis media, sinusitis, and pharyngitis with antibiotics. I'm not going to go into the dosings during the presentation, but they're available in the slides, which will be available to you afterwards. So for acute otitis media, indications to give an antibiotic would be a child that's less than 2 years of age, who has severe symptoms or bilateral acute otitis media, a child greater than 2 years with severe symptoms, and children with recurrent acute otitis media and acute upper respiratory tract infections. We're going to give them a prescription for 10 days. Another thing is to consider augmentative antibiotics in the previous, if they've used antibiotics in the previous 30 days or they've had a treatment failure. So next is acute bacterial sinusitis. So that this is, we want to suspect this when they have symptoms without improvement between 10 and 30 days of illness, or if they're having severe symptoms, an ill appearance or a temperature greater than 102.2, or worsening symptoms. Another thing, if this patient does have a true penicillin allergy, is that we can give them a cephalosporin or levofloxacin if the penicillin allergy is severe. Okay, and last is group A, streptococcal pharyngitis. So this is actually the most common cause of bacterial pharyngitis, whereas 15 to 30% of all cases in children 5 to 15 years old are group A strep. And the signs and symptoms to look for that would indicate a reason to prescribe an antibiotic would be abrupt onset of fever, headache, abdominal pain, nausea, vomiting, sore throat, exudative pharyngitis, enlarged tender anterior cervical lymph nodes, consistent with the center criteria. Another interesting finding was, are shorter courses safer and more beneficial? So there was an article that came out in the Baltic Journal of Medicine that did show that higher doses with shorter duration actually have less adverse effects and faster treatment. If you want to learn more about that, it's in the references. Last but not least, another thing we can think about to improve overprescribing would be a wait-and-see approach in delayed antibiotic prescriptions. So in the Pediatric Journal in 2008, there was an article published that looked into does a wait-and-see approach to the treatment of acute otitis media decrease antibiotic use when a prescription is given? So if I see a patient in clinic and I ask the mom to wait 2 to 3 days and then I'll send a prescription if symptoms are not improved, this is what they looked at, and it did show that there was a decrease in filling these medications. So only 1 in 5 of the patients seen filled a prescription if it was withheld for 2 to 3 days, versus almost half of parents that filled the prescription if it was given right away with the visit, and parents were actually equally satisfied too. So another article that was published in JAMA in 2006 looked, it was a study in the emergency department that looked at the question, will asking parents to delay filling a prescription for the treatment of acute otitis media reduce unnecessary antibiotic use? And the answer for this was also yes. They asked the parents to try ibuprofen and otic analgesic drops to alleviate symptoms instead of giving antibiotic, and it actually decreased the rate of prescribed antibiotics as well. So in summary, narrow spectrum antibiotics are better to use in patients with acute respiratory tract infections, as broad spectrum antibiotics have higher rates of adverse events. So what do we want to do when a child comes into us with a suspected bacterial acute respiratory tract infection? So we want to look for signs. Is it really bacterial, or is this likely viral? Does it need an antibiotic? Does it not? And if it does, then we want to treat with amoxicillin, which is the gold standard. We want to consider the side effects of giving antibiotics unnecessarily, consider the duration. Do they need to be on a longer course, or is a shorter course sufficient? And also consider the cost, not only financial cost, but also is we want to consider the resistance and that might be happening because we're overprescribing antibiotics. Those are my references. Thank you very much.
Thank you, Dr. Smouse. And as a friendly reminder, if anybody has questions for Dr. Smouse, go ahead and leave them in the chat box, and we will get those questions addressed at the end of all of the presentations during that open Q&A time. Our next presenter is from Wesley Family Medicine Residency Program, also here in Wichita. Dr. Marianne Kunsch is presenting Beyond the Rochester Criteria, a prediction rule for severe bacterial infections in febrile infants. Please welcome Dr. Kunsch.
Great. Thank you so much. All right, so I'm Marianne Kunsch. I'm also a first-year resident at Wesley Medical Center, like Dr. Beard mentioned, and I'm going to be talking about Beyond the Rochester Criteria. a prediction rule for severe bacterial infections in febrile infants. So as far as learning objectives for my presentation, first, I want to kind of define serious bacterial infection in febrile infants as well as relevant risk factors. I want to describe the Rochester criteria for severe bacterial infections, describe the updated prediction rule, compare and contrast the Rochester criteria with this new updated rule, and also formulate possible practice changes that are related to the new rule. So this is the reference that was used to kind of base this presentation off of, Kupperman et al. They studied a clinical prediction rule to identify febrile infants 60 days and younger at low risk for serious bacterial infections. So first off, let's talk a little bit about fever in infants. In most cases, 10 to 20% of all pediatric emergency room visits are due to fever. So this is defined as a temperature greater than or equal to 38 degrees Celsius. Most of the time, they're due to viruses. However, 8 to 12.5% of the time, so still a good amount of the time, they are serious bacterial infections. Of those, the vast majority are UTIs or urinary tract infections, but there are 1 to 2% that are slightly more invasive or considered invasive bacterial infections. Those are things like bacteremia or bacterial meningitis. So when you have a kiddo coming into your office or into the emergency department that's coming in with fever, how do you tell the difference between a common cold and something more severe? So first, a couple of definitions. So serious bacterial infections, or SBIs, are invasive infections that can include things like bacteremia, bacterial meningitis, pneumonia, skin and soft tissue infections, osteomyelitis, gastroenteritis, joint infections, and UTIs. Invasive bacterial infections, again, like I said, were things like bacteremia and bacterial meningitis. So as far as risk factors for these serious bacterial infections, there are quite a few. Obviously, if age is less than 28 days, so those 1-month-olds and younger, puts them at greater risk. If they're ill appearing, if their temperature is greater than 40 degrees Celsius, that's kind of a higher risk factor than just a typical fever that's greater than 38.0. If the kiddo is unimmunized, which a lot of these newborns are, at least in the first month or so of life until they get their 2-month vaccines. Prematurity is a risk factor, chronic illness, recent antibiotics within the past week, risk of maternal transmitted infection. So this would be things like if mom was group B strep positive, didn't receive appropriate antibiotics during delivery, things like that. And actually social barriers to follow-up is also a risk factor for severe bacterial infections. So thinking about that, if a baby has a fever and the family doesn't have transportation to get them to be evaluated, they're at higher risk of developing one of these severe infections. So clinical prediction rules for severe bacterial infections have been around for a while. They were initially developed in the 1980s and 90s to guide decision making. For the most part, they used these in the emergency room. They basically looked at historical features, physical examination data, and laboratory data to risk stratify febrile infants into high and low risk groups. There have been several different rules developed, but no single approach has been used uniformly. They tend to name them after cities, as you can see. So things like the Boston criteria, Milwaukee, Philadelphia, Pittsburgh, etc. Many of those required a lumbar puncture and CSF studies in order to properly evaluate infants. The one that I'm going to focus on today and the new rule, the Rochester criteria and the new rule do not require CSF studies. So that's kind of what sets them apart from these other ones. So the Rochester criteria for severe bacterial infections looks at a few different things. So as far as history, they need to be less than or equal to 60 days of age, have a temperature greater than 38, so be febrile. History findings should be a term infant, no perinatal antibiotics required, no underlying diseases, and they can't have been hospitalized longer than the mother. On physical exam, the kiddos that fit into this criteria would be well appearing without signs of focal infection. So things like no focal ear infection, no cellulitis, no particular joint infections, things like that that you can notice pretty carefully. Then you look at labs. So the Rochester criteria evaluated several different labs. They looked at white blood count, and they were aiming for a count between 5 and 15,000, an absolute band count less than 1,500, a urinalysis with less than 10 white blood cells per high-powered field, and it indicated, depending on what they presented with, a stool sample as well without white blood cells. Again, like I mentioned, this particular criteria did not require CSF studies for these particular infants. Based on this criteria, it stratified febrile infants into low risk or high risk categories. If they were low risk, so if they met all of these criteria, so if their white count was, say, 8,000, they were a term infant, they looked otherwise well, they didn't have a focal infection that you could see, their other labs were appropriate, they would be classified as low risk. They could go home without antibiotics, but it necessitated a close follow-up just to make sure that you're not missing something that's upcoming. If they did not meet these criteria, that would place them in the high-risk category, in which case you would go ahead and hospitalize and start empiric antibiotics. So for the Rochester criteria, the sensitivity was about just over 80% and specificity was about 60%. So pretty good overall and improved from the prior rules that had been used. But the new rule we're going to talk about improves on that some more. So the updated prediction rule, the Kupperman-Pekarn group looked at the research question, can clinical features and lab tests identify febrile infants less than 60 days old at low risk for serious bacterial infections? They used a large prospective cohort study, just over 1,800 infants that were 60 days of age or younger. Out of those, they found that about 9.3% ended up with serious bacterial infections, and 30 of them, or about 1.6%, had those invasive infections, so bacteremia and bacterial meningitis. So for fever, they kind of required it to be a rectal temperature that was taken either in the emergency room, in clinic, or at home within the past 24 hours that was greater than 38 degrees. And then they reviewed a bunch of different clinical factors to assess what would make the best prediction rule. So they looked at history findings, physical exam findings. They reviewed a Yale observation scale, which was basically the physician's assessment of the baby's general appearance. So how their cry is, if it's very frantic, if they're soothed by parents easily, if they're interacting poorly with the social surroundings, things like that. So it was more of a general clinician suspicion for a severe infection. And they also looked at labs. So for this updated rule, again, the age was less than or equal to 60 days. They had to be febrile. They had to be a term infant. So no chronic illnesses and no antibiotics given in the last 48 hours for this study. On physical exam, they needed to be well appearing without signs of focal soft tissue infection. They did exclude ear infections just because you can have an overlying infection on top of an ear infection, so they did not include that in their study. Lab-wise, they found that there were 3 that seemed to work the best as far as their prediction rule. They looked at UA, so a urinalysis that was unremarkable, and keeping in mind this was a more strict UA, so it had to be done either with a suprapubic aspirate or a catheter. They didn't use bag samples because they were less accurate. The absolute neutrophil count less than 4,090, and a serum procal level that was less than 1.71. So if all of those criteria were met, then they could accurately rule out severe bacterial infection. In this case, the specificity was about the same, so it was about 60%, but the sensitivity went up from about 81.5% to 97.7%. So they were able to accurately find those true positives. So testing positive for severe infections and being able to rule them out. So the negative predictive value here was 99.6%. So they didn't miss a single infant with bacterial meningitis. So that was kind of a big deal for their study. As far as the updates, there was a higher risk of invasive bacterial illness and also herpes, HSV, meningitis in neonates that are less than 28 days, so that first month of life. So the investigators with this study specifically advised caution before using the Pekarn rule in this particular population, although it did seem to follow their data, that it was accurate, but they recommended kind of additional research before going forward with that. So just to kind of compare and contrast the Rochester criteria versus this updated PCARN criteria, age and temperature were the same, history very similar. So again, term infants, no recent antibiotics, no chronic illnesses. On physical exam, they typically needed to be well appearing without signs of focal infection. Labs is where they differed a bit. So the Rochester criteria looked at the white count, the band count, a urinalysis, and potentially a stool sample, whereas the PCARN rule looked at a UA, an ANC, and a ProCal level. And management was pretty similar. So if they met all the criteria, they were designated low risk, were able to go home, didn't need antibiotics, didn't need hospitalization, and needed to follow up. If they were high risk, then you go ahead and do kind of your complete workup and initiate antibiotics. So the big deal here is really the sensitivity was what was the big improvement was. So from 81.5 to 97.7%, like I mentioned. So why is this important? So these labs can be tested in the outpatient setting. So it's something that we could be doing in our primary care practices that could prevent a family from necessitating an emergency room visit, which would in general be more cost effective and easier on transportation for families. It does not require CSF studies to rule out a severe bacterial infection, which is definitely patient-centered. It's less invasive procedures for infants, and it does have potential to decrease unnecessary testing in those babies that you could rule out a serious bacterial infection. You had an increased sensitivity and excellent negative predictive value, so it tended not to miss cases of serious infection. And it could be useful for febrile infants that were less than 30 days old, which we don't necessarily have a great way to document, but further research is needed there because there are some other severe viral infections and things that they wanted to evaluate. So part of this overall conference was to discuss social determinants of health. The last slide pretty well goes over a lot of those things, but I just wanted to reiterate the importance of some of these things for families and for the patients. Doing these lab tests and avoiding unnecessary procedures can help to decrease medical bills. It can increase the quality of healthcare coverage, decrease morbidity and mortality, and also healthcare expenditures. And it can help to take away some of those barriers to healthcare, such as transportation and things like that, where patients are not necessarily able to get to the emergency room for a visit. So in summary, a serious bacterial infection includes things that are invasive infections like bacteremia, bacterial meningitis, pneumonia, cellulitis, UTIs, and the like. There are multiple clinical prediction rules that have been created in the past, many of them requiring CSF studies. More recently, the Rochester criteria did not use CSF findings, but used other lab findings in addition to their history and physical. The new PCARN rule that was developed uses history and physical as well as those three findings we talked about, the urinalysis, the neutrophil count, and the ProCal, and is more sensitive than the Rochester criteria. It was used in infants that were less than 30 days of age, although additional research, again, is needed to validate that. And it can also offer decreased emergency room visits, invasive testing, and medical expenses for patients and their families. So these are my references. Thank you.
Thank you, Dr. Kunsch. Again, any questions submitted in the chat box during Dr. Kunsch's presentation? Doesn't look like there was any, but go ahead and put those there if you need to, and those will be addressed at the end of the presentations during our open Q&A time. Our final presenter for today is from the University of Kansas Family Medicine Residency Program in Kansas City. Dr. Chelsea Fair will present on Pace Yourself, a review of the SPRINT trial. Please welcome Dr. Fair. Dr. Fair, I think you're on mute.
Gotta unmute myself first. Is that better? Okay, so we'll jump right into it. So for today, I'm going to review the SPRINT trial and specific guidelines and recommendations that we use for blood pressure management. So we'll look at a couple different trials that have guided the guidelines that we currently use. So a little bit about me, which we'll skip. Objectives for today. So we're going to compare blood pressure recommendations from the American College of Cardiology, our very own AFP, as well as the ACP. We're going to look at 3 different trials, and that's where probably a lot of these guidelines are coming from. We're going to look more at the SPRINT trial and how that worked, and basically the limitations and maybe why we don't use those guidelines as they did in their trial, and review the risks and benefits of treating blood pressure. And lastly, we'll do a quick overview of social determinants of health and how treating our patients in clinic is affected by that. So the first article and study that we're going to look at was published in JAMA in January of 2018. And it was looking at the association between treatment to lower blood pressure with death and cardiovascular disease at different levels. So the first thing they did was they looked at treating to blood pressure of greater than 140, and they did show that treating, if your patient comes in, they have a blood pressure of greater than 140, that did show reduced risk for death and cardiovascular disease. Also, importantly, they showed that if your patient came in and their baseline systolic is less than 140, the treatment effect for that was neutral. So they were not able to show a big benefit there, which the SPRINT trial will argue against. But there is a possible benefit of non-fatal cardiovascular events. So that's one of them that has guided our current recommendations. And so here is the famous SPRINT trial in November of 2015. So they had 2 groups. They had an intensive treatment group and a standard treatment group. So the standard treatment group was just treating to a blood pressure of less than 140, and then the intensive treatment group was treating to less than 120. And so they used they're using this in high-risk patients. So these are patients at risk of cardiovascular disease, but they did not have diabetes. And they were showing that there were lower rates of fatal and non-fatal cardiovascular events and all-cause mortality with the intensive treatment group. And we'll go into more of the limitations and what their study did in a little bit here. But it did show that adverse events were more frequent with that lower targeted group. So as you can imagine, there was a significant increase in hypotension, syncope, AKI, renal failure, electrolyte abnormalities. There was not an increased risk of bradycardia or falls, which is some might expect. The next one we'll look at is a study published by The Lancet in March of 2016. So they were just looking at reducing, regardless of what the patient came in at, just adding on a blood pressure medication. And they said that blood pressure lowering significantly reduces the risk of adverse events, regardless of whatever blood pressure they may start with. So for certain patients, which is kind of what we do use, if they're considered to be of absolute risk by ASCVD or because of diabetes or certain cardiovascular history, that regardless of their blood pressure, they could be considered for reducing that, even if they come in those 130s. So here are the different definitions from the various schools of thought that we follow. So as the American College of Cardiology, they consider elevated even in that 120 to 129 range. They don't treat at that range. In stage 1, which they consider 130 to 139, they do consider treatment if the patient has diabetes or if their ASCVD risk is high, they have CKD, or if they've had a previous like MI or stroke, then they do consider treatment at this 130 to 139 range. And then like we do, I'm sure with AFP, over 140, they're going to consider probably starting a medication. And then hypertensive emergency or crisis, a little bit outside of the scope of today, obviously looking for end organ damage and treating that if needed. So the AFP has similar guidelines. We are not quite as strict with the less than 130, but we also put ranges on for age. So for the general population, if you don't have diabetes or chronic kidney disease and you're older than 60, then we actually are a little more lenient in our guidelines. And if you come in and your blood pressure is in the 140s, we will let you stay there without adding to your medications or giving you a medication if you're not already on some. So over 150, you would treat in a patient that's greater than 60. If they're less than 60, then our target is similar to the stage 2 of the ACC, and that's treating to the systolic blood pressure of less than 140. But we also take into account those special populations. So if you do have chronic kidney disease up until age 70, our target is still less than 140. And if you have diabetes, then regardless of age, we are treating to less than 140. And this talks a little bit about, I'm sure, medications that we're all very aware of and which ones to add. So thinking of your different populations, and for CKD, we're thinking about ACEs and ARBs and African-American population. You think earlier about your hydrochlorothiazide or calcium channel blockers. They also state in the AFP guidelines the importance of compliance. And so if you're considering lisinopril and hydrochlorothiazide, might have better compliance if that's all in one pill. And there aren't really great guidelines of whether maxing out one drug before adding the next, or if you want to add an additional drug before that first one is maxed out. And then these are the recommendations, the grades of these recommendations. So the highest recommendation that we have is going along with what I previously mentioned. So greater than 60, if your blood pressure is 150, there's really good evidence to treat that to reduce your risk for stroke, cardiac events, possible mortality. If you're greater than 60 and you've had a history of a stroke, then there's moderate quality evidence to treat to less than 140. And if you're greater than 60 and you're at high risk for a cardiovascular event, again, by diabetes or using your ASCVD scoring, then you also could try and treat that systolic to less than 140. So more in depth on the SPRINT trial and maybe why we don't want all of our patients in that 120 to 130 range or less than that. So importantly, as a second point here, a lot of our patients have diabetes, and importantly in the SPRINT trial, they excluded any patient with diabetes. So obviously this fails to give us information on a lot of our patients, and so that would exclude a good study that would exclude lots of our diabetic patients. The next point I'll try to explain here is that greater than 90% of the patients enrolled in the SPRINT trial were already on blood pressure medication when they enrolled. So their original blood pressure was likely not in the high normal range as the study stated, but it was likely already at stage 1 or stage 2 hypertension. And they were already under a very clear-cut blood pressure lowering influence. So the study doesn't necessarily look at what, let's say, your blood pressure is in the 160s, and we already know that that patient is going to get great benefits from lowering their blood pressure. The study doesn't show that it's a lot more beneficial to lower it below 130. It was just showing reduced cardiovascular risk. And then the other couple points here also, that they used the automated cuffs, which maybe a lot of your clinics do as well, but those actually tend to estimate blood pressure about 10 to 20 millimeters of mercury below what you would get if you auscultated yourself. And so their values may have been a little skewed in that sense. And as we already mentioned earlier, that intensive treatment group did not come without adverse events. So I don't think those things can be overlooked. And that's probably why all of these, none of the current large groups recommend treating to that lower blood pressure like they did in their intensive group study. We talked about the risks and benefits, and won't go into that more. I thought this was a good table that kind of summarized, this is actually from the European College of Cardiology, but I liked that the table summarized maybe a good way to stratify risk and decide if you're going to treat or not. I know the AFP, we generally don't treat if, if the patient comes in and they're 130s, we generally don't treat, but this, I thought this was a good table that maybe showed, maybe in some of those cases, there is a case to make. So if they have hypertension mediated organ damage or CKD or diabetes, and their blood pressure to us really is probably normal, 130s over 85, then they're in that moderate to high risk range, and you could consider treatment at that point. If they also are, if they've already had established cardiovascular disease or, CKD, a grade stage 4 or greater, then even more reason to treat to that 130 over 90 range. I don't think there's probably much benefit to treating to the 120 like the SPRINT trial did. So I thought that was a good summary of those recommendations, and that I think with our patient populations, always targeting the less than 140, if they're not really old, but you could consider in some populations that it might be beneficial to treat to a slightly lower target. Lastly, we'll touch on social determinants of health. So obviously we always have to keep in mind, will our patient actually be able to take this medication? What's keeping them from optimizing their blood pressure? So generally, thankfully, medications for blood pressure are usually pretty affordable, but you could still consider that adding up if they're on a lot of different medications. So the other things we have to think about is, our patients having places to exercise? A lot of them can't afford going to the gym. Maybe it's not safe to go walk around their house. They might not have the best access to foods, so they're eating a lot of fatty foods, high salt foods, not a lot of fruit and vegetables and things like that. And then lastly, it's important to think about our patients' health literacy. If you, say, for example, you have a patient come in and their blood pressure's 160 over 90, and they feel perfectly normal. In fact, today I saw a patient with blood pressures in the 190s, and she's probably had this blood pressure for years, has not seen any, doctor for 5 or 10 years. I've done labs on her. She doesn't have any end organ damage. And so educating her that, yes, I know you feel fine, but yes, I want you to take this medication every single day of your life. Don't miss any doses. I think educating on that is important, to educate on what this can actually cause in the long run. And I think that's it.
Thank you, Dr. Fair. This concludes our presentations for today. It's time for our open Q&A session, so I would invite anyone to leave some questions in the chat box if you're interested. And I do see a comment from Dr. Curry about appreciating confirmation to empower, but wait and see, and there is some data to support that. Just as a comment, I don't usually comment, but here's a comment that I left in the chat box about an opinion piece that was in JAMA just this past month about doing antibiotic prescribing, the wait and see approach. And it was just an opinion piece, so of course there wasn't a lot behind it, but the comments from Dr. Mark A. Bell after the opinion piece was pretty interesting. So there is a good discussion, even among all of our academic physicians, about whether or not a delayed prescription is really what we should be doing. So just interesting, and an opinion piece. Any other questions I would invite in the chat box? Okay, well, I'm going to go ahead and thank all of our presenters for today. Dr. Smouse, Dr. Kunsch, and Dr. Fair for their presentations. It was a very good, good synopsis of just different pieces of literature that's out there. So thank you for participating in our webinar. And as this session wraps up, we'll send an email link to an evaluation for today's speakers. I think Michelle was going to also leave it in the chat box. And if you'll take a moment to provide your feedback on the presentations, as well as the virtual format that we've provided to everyone today, so we can give some thought to maybe doing more presentations like this. If you want the KAFP to report your CME for today, there is a place in the survey where you can indicate that. I hope you all have plans to join us on Thursday, June 11th and Tuesday, June 16th at the same time to hear the remainder of our resident presentations. And the staff will put a link to register for those sessions in the chat box. And thank you for joining us today. I am taking one last look at the chat box, and I don't see that anyone has any further questions, but it looks like Michelle is going to send a copy of the PowerPoint slides as well as a link to the evaluation to everyone's email. So I appreciate everyone coming today and also supporting our residents and the KAFP. Thank you so much.